Okay, thank you very much. Thank you for inviting me. My talk is optimizing PEEP in the prone position. I have to say this is a relatively data-free zone, so I will do my best. Here are my disclosures. And I'm sure in the previous talks here, people have discussed the benefits of prone positioning. It's been used for decades in patients with ARDS. Physiologic benefits are relatively well described, so improved ventilation perfusion matching, recruitment of dependent lung regions, optimized chest wall and lung mechanics, enhanced draining of secretions. Use is common, and of course it became much more common during COVID-19. The appropriate ventilator settings, however, have really not been studied systematically. This is the key paper in the literature on prone positioning, came out in 2013. Somewhat surprising result, actually, because there had been a long history of negative studies in prone positioning before that. And if you look here, this is the order of publication of prone positioning papers. You can see starting in 2001 with Gattinoni's paper. And this is the cumulative odds ratio for benefit in prone positioning. So adding each study together, you can see how slowly the evidence built towards a positive message and a positive result for prone positioning overall. So this is a great study in science of how we incrementally learned and studies developed, each one on top of the previous study. So what were the changes that occurred over time? There were several key changes in the studies that were implemented and that probably account for the survival benefit. So we learned to have a higher proning dose. We kept patients in the prone position for longer. We enrolled patients early, the royal we, I didn't actually enroll anybody, but we enrolled patients earlier in the studies. We honed in on the patients most likely to benefit, so the P-DEF ratio of less than 150. There was obviously experience gained in the procedure. We all learned to prone really quickly during COVID-19, but it's not a benign procedure. We have to learn how to do it. But the studies didn't address the ventilator settings. And what happened was each study used the common ventilator strategy at the time the study was designed. So how did that look? You can see pretty clear cutoff here. The first studies all used high tidal volume. And that may well have been the reason that these studies were negative. So we continued high tidal volume from the supine position into the prone position. It's only when they began to use lower tidal volumes in the prone studies did we begin to see the effects. Now, it was low tidal volume in both arms, so it's not that the low tidal volume was the reason that the study was positive. It's just that implementing low tidal volume seems to have somehow improved the benefit of prone positioning. Now, do PEEP settings matter? So tidal volume settings do. We need to use low tidal volume during prone positioning. What can we learn from the studies? So here you see a series of the recent studies in prone positioning. You can see the PEEP level delivered in that study, and you can compare that to the PEEP levels that you would have gotten in one of the high PEEP trials. Okay, so all through these prone positioning studies, they used essentially moderate levels of PEEP. So this was the PEEP at baseline. This was the PEEP post-proning, and it was essentially between 8 and 10 in all studies. So very moderate levels of PEEP applied in the positive prone studies. And the question is that appropriate, or is there additional benefit that can be had by changing our PEEP strategy during proning? And here the literature gets sparse. So let's start to look at what happens to the chest and to the lungs when we prone a patient. And what are we actually looking at PEEP to do? So here you can see a sketch of what an ideal PEEP level would look like. So it's one that balances the risk of atelectasis trauma, so it expands the lung. At the same time, it prevents the injury from overdistension. And we think, the goal of every PEEP trial is to find where this sweet spot is, right? We can say it another way, and this is slightly more controversial, but I think most people would agree that sweet spot is around a transpulmonary pressure of 0. So it's at the point where the chest wall, the pressure of the chest wall downwards is overcome by the pressure in the airway, inflating the lung, keeping the lung opened at end expiration. That's slightly controversial, but not that controversial. So we need to think about what happens to the transpulmonary pressure during prone positioning. So here's a study we did. This is in healthy patients in the operating room. They were getting spine surgery. And we placed esophageal balloons, and we looked at their expiratory reserve volume. And you can see what happened to the esophageal pressure during proning was essentially a decrease of about 5 centimeters of water in every patient. Okay, so if the pressure in the esophagus, so the surrogate for the pleural pressure, goes down, that means that the transpulmonary pressure goes up, because transpulmonary pressure is airway pressure minus esophageal pressure. So minus, that's a plus, and you get an increase in transpulmonary pressure. In other words, when we prone a patient, functionally we're increasing the PEEP by 5, because that's what the esophageal pressure changes. Now, you may say, does the position of the esophagus change when we prone the patient? So surprisingly, and unlike what we may remember from the anatomy lab, the esophagus is essentially a mid-thorax organ. It's not in the posterior portion, and the positional change as we prone the patient isn't that large. Now, that increase in PEEP will measurably increase the volume of the lung. And you can see that here. So this is the expiratory reserve volume of the lung of these patients, and it went up pretty predictably. So already we know that by simply proning the patient, we're functionally increasing the PEEP. What else happens to the chest? So multiple studies have shown that the chest wall elastance increases in prone positioning. And elastance, the inverse of compliance. So what that means is the chest wall gets less compliant when we prone a patient. And probably that has to do simply with positioning. The anterior portion of the chest, which is more flexible, is pushed down on the bed by the weight of the patient, reducing the compliance of the chest wall. So if the compliance goes down, the elastance goes up, what does that do to the distribution of air in the lung? And this study, this is really a key study by Katira, Laurent Bouchard, and the late Brian Cavanaugh, showing what happens when we prone patients. So several key findings here. One is the gradient of the pleural pressure becomes much more homogeneous. So this is the gradient of the pleural pressure across the lung during the supine position. This is during prone positioning. So the distribution of air in the lung becomes more homogeneous due to those changes in chest wall compliance. And you can see the same during tidal ventilation. So this is dependent and this is the non-dependent and the dependent areas of the lung in the supine position, okay? And you can see there's a real difference in the distribution of ventilation at any level of PEEP during supine positioning. That seems to disappear in the prone positioning. Okay, that means that essentially any level of PEEP will give you the same effect in the distribution of ventilation in the lung, possibly meaning that the effect of PEEP during prone positioning is less. And you can see here the tidal recruitment improves during prone positioning in the dependent areas of the lung. So this is supine. You can see this is the dependent areas of the lung. This is the non-dependent. When we flip the patient, the non-dependent areas are aerated much better than they were during the supine positioning. On the other hand, this new distribution of air in the lung leads to less hyperinflation during prone positioning. So PEEP appears to be more benign during prone positioning. We can image this. So here are EIT images that show bedside assessment of the prone positioning. Now, obviously there are people who respond better or people who don't respond to prone positioning, but we can see in this responder here an improvement in ventilation, an improvement in perfusion after proning, and an improvement in the VQ matching during proning. Okay? So that's improved distribution of the ventilation. We can see that on CAT scan as well. So we're all familiar with these images of how consolidations seemingly disappear during prone positioning, so supine prone. But we can view the improvement in normally aerated lungs as compared to the supine positioning, and fewer areas of deaeration. Okay, so this is a lot of areas of collapsed lung here. Over-aerated lungs, so this is hyperinflation. That's disappeared as we prone the patient. So much more homogeneous distribution of the air in the lung during proning. All of these things probably mean that what we do specifically with PEEP may be less important. And there's only a couple of studies in the literature that have looked specifically at PEEP. This one here looked at the effects of low PEEP, high PEEP, and prone positioning on the P to F ratio, and you can see that moving the patient from low PEEP to high PEEP didn't give us much of an improvement in oxygenation, but proning substantially did. And that's probably due to that better VQ matching due to better distribution of ventilation during prone positioning. And you can see here also improvement in shunt fraction during proning that you don't see at high PEEP. This study compared PEEP FiO2 table to an esophageal balloon guided strategy of PEEP, and they showed essentially that the esophageal guided PEEP strategy was not different from empiric PEEP during proning, and that the regional compliance was not different. So either method worked equally well. And here, this paper showed an improvement in oxygenation during prone positioning, regardless of the PEEP strategy. They compared 3 strategies here: ARDSNet, best compliance, and transpulmonary pressure guided PEEP strategy. As we demonstrated in our paper, you can see that proning the patient improved the transpulmonary pressure in no matter what the strategy was. So here, the transpulmonary pressure at end expiration was negative. Here it became positive just through the act of proning. This was transpulmonary pressure guided strategy, so it didn't change, obviously. The PEEP requirement was reduced in prone positioning in any strategy, and that the PL driving pressure, so the transpulmonary driving pressure, which is really what we want to target with our PEEP strategy, was similar no matter what the strategy was. So how do I conclude? Prone positioning functionally increases the PEEP. It decreases pleural pressure and increases transpulmonary pressure. So just the fact that you've proned the patient is going to lead to a higher level of PEEP. The changes in the chest wall elastance lead to a better distribution of ventilation during prone positioning. These effects are independent of PEEP technique. So whatever you're doing prior to proning, just keep doing that after proning. My suggested approach is keep the same level of PEEP as the patient has in the supine position when you prone them. Wean PEEP with caution. I would wean the FiO2 before I wean the PEEP, because the real danger here is when you move the patient again to the supine position. And that's probably why a lot of patients deteriorate when you put them supine again, is you've weaned the PEEP down, and as soon as you remove those effects of proning, functionally the patient begins to de-recruit in the supine position. So to me, that's the real danger. It's not proning them. There, the PEEP will work pretty much whatever you do. It's when you put them in the supine position again. So thank you very much.